All right, everyone, welcome to the October 31st, 2024 Board of Health meeting. It is 12:32, and we will call the meeting to order. I will look to Ann for assistance with roll call.
Commissioner Josh Kearns,
Here.
Commissioner Amber Waldron,
Present.
Commissioner Mary Cooney,
Here.
Councilmember Michael Cathcart,
Present.
Board Member Monica Blykowski-May,
Present.
Board Member Charlie Duranona does not seem to be here. Board Member Patricia Keinholz.
Here.
No. We do have a quorum.
And Board Member Charlie Duranona did notify us that he was not going to be able to be present. He's traveling today. Okay, that brings us to citizen input. We do have 5 individuals who have signed up here on the sheet. So, and actually, I'm sorry, but before I get quite that far, I just want to tell all the folks that are watching online or watching the video after the fact, all of the documents and information that we have in front of us is available on the SRHD website. You just go to the meetings tab, and that is where you will find the documents. And then for board members, as always, please try not to have more than 6 microphones on at a time, or they do get a little finicky. And then all the written comment is provided in the binders as well. So that will bring us to open public comment, citizen input. As I stated, 5 people have signed up, so we will go through one by one, 3 minutes apiece. Please, if we can, please try not to have any applauses or booing or any type of cheers or jeers from the audience. That would be appreciated. And we will lead off with... Ooh. Right here. First name? Luis Manriquez. Sorry. Sorry. No, it's okay.
All right. Thank you to the board for letting me speak. So I wanted to speak in favor of discontinuing the feasibility study and maintaining treatment services within the health district. I wanted to start by thanking Councilmember Cathcart and recognizing your efforts to publicize and pass the public emergency around the opiate crisis. And also recognize the results of the work that's been done already on this feasibility study. It's no problem, I don't think, to raise this question and consider, is there a better way to do things? And I think the responses from outreach so far, at least the things I've been a part of, have been overwhelmingly on behalf of recognizing and wanting to maintain treatment services within the health district. And so I think, if we ask people what they think, we should take seriously what we hear from them. As a provider, as a frontline provider, I'm not here speaking on behalf of my employers, but I am a frontline street medicine worker. I work with people dealing with substance use disorder on a daily basis. And I would say that central to recovery is relationships. And I think part of the results that we've seen is the amazing work that our treatment services have done in building relationships with people, helping maintain their adherence to substance use medication and avoiding relapse. And so we should take a lot of pride in the work that treatment services has done. And we should also recognize the serious harm of disrupting those relationships, which is what many people receiving services have said, the harm of disrupting those relationships by privatizing health services. And to the point of privatizing health services, as a provider, having multiple agencies to work with is not a problem. That actually provides some cushion and support. There are all sorts of reasons on the road to recovery that someone may run afoul of one organization and be blocked out because of relapse, because of behavior, and having someone else that they can work with when they have another chance, when they're trying to build things up, is a benefit. And so having multiple providers is not a problem. And the other piece about having multiple providers is that we have and have had for years multiple private agencies that are working in this space. So the only argument that I have heard that is worth entertaining about privatizing is that maybe there are private organizations that could handle these issues better. They could scale up need and address community need more effectively. And they are welcome to in our current system, right? We have a market system. We have multiple providers. They all have the capacity to increase their resources to the extent that they see community need. And so treatment services is in no way a barrier to their efforts, and therefore, the privatization is unnecessary. Thank you.
Perfect timing. Next up, Hadley Morrow.
Leave that there. Not touching the button this time. Hi everybody, I'm Hadley Morrow, Spokane resident 99223. I'm coming at you this Halloween as a cute little skunk to say it would really stink to lose the opioid treatment program as a public part of the SRHD. I don't think community is asking for infinite expansion of this program, but really continuing to serve the clients that are currently there, especially underinsured, uninsured veterans, incarcerated, pregnant people who are being uniquely served by the benefits of this being in a public institution. There's really rich opportunities for expansion through public-private partnership and other methods that could allow us to continue to meet the need without thinking that we need to grow this program in infinity. And it also doesn't necessarily require us to move forward in the feasibility study. So there are opportunities to expand that we could explore without, while still pausing the study. The reason that it feels so important for me to stop the study is because currently any moving forward signals to clients and providers that the intent is to transfer the program, and that is creating a lot of fear. I'm not going to put someone on record without consent, but I do have 5 voicemails from a client who called me every day for the last 4 days because her counselor has quit. She's been in the program for 15 years. This is signaling to her, and this process has signaled to her that she believes that she will lose her care. In these voice messages, she asked me multiple times, will she lose her care? And if this program goes to a private institution, will they still keep her as a federal client? I tried to reassure her. I did so much to reassure her, and I really echoed the words that you all shared, that your intent is to make sure that no one loses care in this. But I did question why I am the one fielding this level of concern when you all are the ones who hold the responsibility for stewarding this process. So in that, I also want to add that regardless of if you move forward or not, which I really hope we do not, I do think it's really important to consider how the ripples have affected the community. And that it's really important that we consider a trauma-informed process, and I hope it leads you all to think about where there's opportunities for more thoughtful community engagement and places where the board and leadership can be directly involved in clients getting to speak, getting to share their opinion, providers getting to share, and really be in part of the process. If this moves forward, it is so important to me that clients and providers get to be centered in decision-making and forming whatever plans that you make, because currently I was really, really proud of a feasibility study that centered community voice and asked community impact to be the first line of defense, really, and to have the first right to say this isn't going to work for us. And moving forward, to me, really, really signals a lack of care and a lack of intentionality towards those clients who, unfortunately, still don't feel like they have the vehicle to come here today. I have a text messages full of clients who said they wish they could have been here, but they could not get off work, or they were at chemo, or they were doing things that are so important to make it possible for them to be thriving, wonderful members of this community. And I do not want to see their care disrupted. I really appreciate the intent to figure out how this institution can be part of meeting a very huge need in this opioid crisis, but this is not the time to be destabilizing the program in this lifeline service. Thank you so much. Please don't make clients roadkill in your moving forward. I had to fit that in at the end. I couldn't quite line it up, but I hope you appreciate the beginning and the end puns. Thank you. Happy Halloween.
Okay, next up, Caitlin Costanza.
Hello, is this on? It's green. Okay, thank you. Sorry, I'm nervous. I've never done this before. My name is Caitlin Costanza. I'm a first-year medical student at the WSU Elson S. Floyd College of Medicine. I am coming here today to oppose the privatization of these services. One of my caregivers as a child utilized opioid addiction treatment services that would not have otherwise been available to her if they were privatized, for being like uninsured and low income. And like Dr. Manriquez said, the relationships that are built between provider and patient are really important. And that's something that's been really ongoing in my life and has enabled me to pursue the education that I've been able to pursue. I would like to voice my concern regarding for-profit medical and healthcare service institutions, and I do not trust that moving this service to a private entity will benefit the patients, providers, or our community widely. While the service would still be available in a private setting, I just don't trust that a for-profit institution would have the same desire to reinvest funds in the participants and provide the same benefits to providers that currently work on the front line as I hope to do in the future. As a future physician and beneficiary of these services directly, I am firmly invested in keeping addiction treatment services as a public service and part of our public health infrastructure. I also urge everyone to consider the feedback that many other community members have offered regarding the feasibility study. Thank you.
Thank you. Next up, Dr. Pam Kohlmeyer.
I have nothing profound to say other than thank you for all that you do. The opioid issue that people are speaking on today is such a crisis in our community, and it needs to stay a service that our public health department has oversight of. I know it sounds like it makes sense to try to privatize. Maybe in private practice, people can do better, they can be more effective with treatment. But the reality is we exist as a public health agency to help people with public health issues. And the crisis really is something that we need to keep in-house. If people want to also have private services on the outside, that's great. But please keep this as an in-house service. You have amazing employees that really devote themselves to keeping our community safe and healthy. They're beautiful people, and they're very devoted to what they do. Please keep this in-house, because those relationships that they built up over years, they're not just widgets that you can replace so quickly. So please keep it in-house. It will help save lives. Thank you.
Thank you. And the last name on our list is Susie Saunders.
Hello everyone, my name is Susie Saunders. I am a union representative with Protect 17, which is the union that represents the majority of workers in treatment services and also at SRHD as a whole. I want to let you know that since the feasibility study was announced earlier this year, 6 substance use disorder counselors have already quit. Staff morale is at an all-time low. Employees are worried about what privatization would mean for their patients, their workload, their pay and benefits, and their ability to provide for their families. Patients have expressed their worry and fear over what privatization would mean for them. For the patients who are seeing one of the 6 counselors who no longer work here, some of those worries and fears have already materialized. Their care has already been interrupted. Some treatment services staff have worked in private clinics before. They could tell you about the dark side of private treatment centers, where patients are treated like piggy banks, caseloads are astronomical, and counselors are only allowed to spend 15 minutes with patients, even if the patient is in crisis. We now know, thanks to all of Dr. Thompson's research, that SRHD Treatment Services is doing a fantastic job. They are a statewide model for how successful substance use treatment can be in a public health setting, where staff aren't constantly worried about the bottom line, where patients aren't at risk of being dropped due to an inability to pay, and where wraparound public health resources are readily available in the same building where people are receiving treatment. I urge you again to stop the feasibility study and let these folks get back to the great work they do for our community. This program is a success, and we should be focused on making it better, not dismantling it. Thank you.
Thank you. And I was told there's one more individual who would like. Oh, please come to the microphone and state your name and.
Sorry, I was late.
It's all good.
My name is Danya Sanders. I am the clinic manager for treatment services. I have been there for almost 11 years. This feasibility study is one that has been talked about prior to me even working here. My wife worked here for 20 years, and the conversation about treatment services being under a public health umbrella has been a conversation ongoing. What is good about this is that it was brought forward by Alicia to see if it was a good idea to take it out from underneath that umbrella. But as we've discovered, this is not a good idea. It's not a good idea. We need to stay here. And the reason is, what I like about the fact that this was brought forward is that that brought the conversation forward. that we need to change how we're doing things. We need to offer more for our clients. We need to step forward and see what we can do better for them, because the last meeting that was here, what bothered me the most was when someone said, and I don't know because I have my little tiny screen, let's do the research and see who can do it better. We're public health. We can do better. We should be doing better. We should be the best at treatment services. That's what, I mean, we have an amazing team. And as they said, we have lost staff because of this, and it's caused a ton of fear. It's not okay. We need to be able to take care of our clients the way that we know how, with the support of this board. And under her guidance and Misty Chalonor's guidance, we need to be able to do the fantastic job that Eastern Washington deserves for our clients. And we need to stay. Thank you.
Thank you. Okay, those are all the names that I have that have signed up, so we'll move along our agenda. Bring us to board reports. So we will come down. Chair report, I will just touch on, we had our executive committee meeting 2 weeks ago, I believe, and went over the agenda today and just sort of, everything will be highlighted as we move through the agenda. But as always, thank you to staff for preparing the work and keeping us on task and organized for today. That'll move us on to the other committee reports, budget and finance. Commissioner Waldron or Commissioner Keeney, whoever wants to. Go ahead.
I can. So when we met, we had a special meeting to discuss the resolutions that are going to be before you. So we'll be discussing those as they come forward. So, so our resolution on the fees, the budget, and what we'll be requesting from the Board of County Commissioners.
Okay. Councilmember Cathcart, Policy and Education Committee.
Yeah, we met on the 16th of October, and we just went over again, the agenda, which sounds like a policy for, so next we're going to do board approval. And also we just discussed penalties on resolution 1601.
Okay, thank you. All right, that moves us on to the consent agenda. Consent agenda, we have a couple of items here. Items 5A through E. We got our meeting minutes from September 26th, the vouchers for September, contract, Spokane County interlocal agreement regarding adult overdose fatality, multidisciplinary case review panel. Then we have two contracts, one with Camtech Integrated Security Systems and Kipu Health. Anything, does anybody have any questions on those or anything anybody would like to take separately? Otherwise, I'd be open to a motion.
Move to approve the consent agenda 5A through E.
Second.
All right, we have a motion and a second. Any conversation, comments? Seeing none, all in favor say aye.
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 Motion passes unanimously. All right, that will bring us to number 6, which is an executive session item. I will look to our legal representative to state the purpose and who she would like present.
Thank you. The board will go into executive session pursuant to RCW 4230-110-1I to discuss litigation or potential litigation or agency enforcement. For the first issue, I would ask, of course, the board members, myself, Dr. Thompson, and Dr. Velasquez to stay, and I anticipate will be 20 minutes.
Okay, no decisions will be made while in executive session?
Correct.
Okay, all right, so it is 12:51. We will let some folks clear the room, so we will say we will start at 12:53, and as stated, for the purpose, and 20 minutes. Okay, we have come out of executive session. It is now 1:26. We did extend our time. No decisions were made while in executive session. That will bring us to our action items, and we are going to lead off with item 7A. This is Resolution 24-08, adopting the 2025 SRHD fee schedule. I'll turn it over to Kim Kramars for a presentation.
Good afternoon, everyone. Bringing forth the first resolution of the day. And I want to take a moment first to thank the committee members, Budget and Finance Committee members, Commissioner Cooney, Commissioner Waldruff, and Patricia Keenholz for working with us this past year on all things financial, going through the budget this year, and also the fee schedule. Today I'm bringing forth the second touch of both of these items. So for the fee schedule, bringing forth Resolution 24-08, adopting the 2025 Spokane Regional Health District fee schedule. Whereas the Spokane Regional Health District Board of Health has determined that revenues from fees are necessary to provide funding for public health services in Spokane County. And whereas in accordance with Resolution 24-07, Health District fee policy, fees are to be determined periodically. And whereas RCW 70.05.060 provides that the board shall establish fee schedules for issuing or renewing licenses or permits for such other services as are authorized by law and the rules of the State Board of Health, provided that such fees for services shall not exceed the actual cost of providing any such services. Therefore, be it hereby resolved that the Board of Health does hereby adopt the attached Spokane Regional Health District 2025 fee schedule. So I'm looking for consideration of approval of the fee schedule for 2025.
Motion to approve?
I'll second the motion. Sorry, our chair had to step out for a second, so I'll take over the meeting. Is there any discussion on the motion? Commissioner Cooney.
Yeah, so this is the second touch, so everybody saw this last month, had the opportunity to look over. As far as I know, we have not had any questions or comments that have come back before us. Finance Committee did look at this thoroughly and approved it to move forward, so I just want to give that information.
And just to follow up on that, I really appreciate the work you do every year to make sure the fees are fair and that we're not over collecting, and that if we do, we put it back in and we don't raise that fee for the next year. So I appreciate all the hard work that your team from across the district on the fees. So thanks, Kim. Good job. All right. Well, if there's no further discussion, we have a motion and a second. All those in favor of adopting the 2025 SRHD fee schedule, please signify by saying aye.
Aye.
Aye. Any opposed? None opposed. Passes unanimously.
Thank you. Appreciate that. The next resolution brought forth today is Resolution 24-09, and as Commissioner Waldruff mentioned, this is the second touch of the budget. I did present more details related to the budget at September's meeting. So this is adoption of the 2025 Spokane Regional Health District budget, whereas the Spokane Regional Health District Board of Health met September 26th, 2024 and October 31st, 2024 to examine and set the health district budget for fiscal year 2025. And whereas after careful examination and consideration, the expenditures and revenues for fiscal year 2025 have been set at $57,573,563, and they're noted below in the chart. This is a balanced budget, and so we're looking for consideration for approval of the 2025 budget.
Are there any questions for Kim? Otherwise, be open to a motion.
I'll move approval.
I'll second. All right, any discussion? Commissioner Cuny.
I will just state again as the finance chair that, again, this was reviewed. This is the second touch to the board members, and I don't know that there's been any questions or comments to the board or that has come from the board, so Finance Committee moves to approve.
Okay. Any other comments? Seeing none, we,
I was just going to say, I just really appreciate, again, all the divisions across the district working to meet the challenge that all the county departments have been challenged with, which is to try and come in at your 2024 levels for 2025. So I really appreciate the hard work and close scrutiny that you did. And I know next year we'll probably have to do that again because of the tight budgets and inflation that's impacting all of our local government budgets. So thank you for the hard work to do that and come prepared.
Okay, motion and a second. All in favor, say aye.
Aye.
Aye. All right, motion passes unanimously.
Thank you. The next resolution, I think is sponsored by Commissioner Cooney as the chair of the Budget Finance Committee. I'm happy to introduce it if you'd like. It is, as Commissioner Waldruff mentioned, a flatline budget, so our ask of Spokane County collectively between the TV program and the overall budget is the same ask as 2024. But would you like me to read it? Or? Okay. Resolution 24-10, requesting the Board of County Commissioners for Spokane County to provide unrestricted funding in the amount of $2,053,960 to the Spokane Regional Health District for the 2025 budget year. Whereas the Spokane Regional Health District Board of Health is responsible for the financial oversight of Spokane Regional Health District, and whereas at the September 26, 2024 regular meeting of the Board of Health, the Board of Health Budget and Finance Committee Chair provided an in-depth review of the Spokane Regional Health District budget. Whereas Spokane Regional Health District, in order to fund its 2025 budget, will require $2,053,960 in local unrestricted funds to provide public health services for Spokane County. Whereas this amount is separate from the interlocal agreement that funds $420,885 for the tuberculosis program for Spokane County. Whereas Spokane County is the local funding agent for unrestricted funding for the Spokane Regional Health District. Now therefore be it hereby resolved by the Board of Health that the Board of County Commissioners for Spokane County is requested to allocate necessary funding to Spokane Regional Health District for the 2025 budget year in the amount of $2,053,960.
All right, any questions or comments? Commissioner Cuny?
I can comment before the motion this time. So yes, so again, this is kind of what is needed in unrestricted funds to fill the budget gap, which is the same as it was last year. Even though we have 3 commissioners that are sitting on this board, this is just a recommendation that is coming from this board to the Board of County Commissioners. The Board of County Commissioners as a whole will then make the determination as to what the full funding is at the Board of County Commissioner level. So this is just a request that is moving forward, so therefore the commissioners do not need to recuse themselves at this point.
Okay. Is there a motion on action item 7C?
Move to approve?
Second.
Motion and a second. Any final comments? Seeing none, all in favor say aye. Aye.
Aye.
Aye.
Motion passes unanimously. That brings us to action item 7D. I will turn it over to Dr. Thompson.
Thank you. Thank you. So, good afternoon. And at the September 26th Board of Health meeting, I was asked to produce a business plan that showed historical data on treatment services with number of clients served and number of FTE. We were also asked that a business plan describe how much it would cost to expand our services to accommodate the clients we have been turning away. As of October 30th, the number of clients turned away due to no available slot since July 1st has gone up to 146. I want to acknowledge that this pro forma was prepared by Julie Shiflett of Northwest CFO from data that was provided to her by us. She apologizes that she is not able to present the work in person due to prior commitments. So the sources of data that Julie used were financial and statistical information provided to her from our finance division. The treatment services division director, in consultation with her team, provided the target for number of enrolled clients per week. Julie used this estimated number of assessments, Julie used the estimated number of assessments needed to achieve the 1,400 target, and the estimated number of FTE that would be needed to achieve the target. This is a very, very busy slide. And you have a hard copy in your packet, and I believe there are hard copies on the back table as well. And so, and I forgot the pointer, because it is a very, okay, good. So what this is providing you is historical data, and it goes through 2019 actuals all the way through September year to date. Okay. Again, the 2019 through 2023 are the actual expenses for the entire year, and 2024 shows the expenses, the actual expenses to date. So these aren't, this whole spreadsheet, none of this is budget or estimated. It's all actual numbers. So when we start looking at the rows across, what do the rows across mean? That first row provides the number of unduplicated clients served. The second row is the number of assessments conducted. The third row is the average enrolled clients per week over the course of the year. The fourth row is a ratio of average enrolled clients divided by the number of OTP assessments that have been conducted. The drop in this ratio for year-to-date 2020, it's highlighted right here in the blue, is influenced by the decrease in staffing and availability of slots, assessment slots. And this ratio is important for when Julie starts putting together the pro formas for how much would it cost for us to have, on average, 1,400 clients a week being served. The fifth row is also a ratio of the number of OTP assessments divided by the number of FTE. A higher ratio means there were more assessments conducted by fewer staff. And again, that ratio is used when she goes into the estimates for cost. The next line shows the number of mental health assessments, and the decrease in the number of these assessments is directly related to the 2 vacancies in this program. And on the next line, we have 2 things going on. First is the average number of FTE and the average salary for employees for that year. The increases are related to the average number of employees, step increases, and negotiated COLAs. The line below, right below the average FTE, that's showing the percent increase in average salaries from the prior year. So I just want to make sure everybody knows that's an increase from the prior year. It's not how much salaries increased. Okay. The remaining rows break out the expenses and revenues along with the percentage of the total expenses or revenues for that year. The increase in services, again, highlighted here in blue for 2023 and 2024, are primarily influenced by the addition of the building expenses. So when they were here, it was, that expense was included in the indirects, but now they're paying for those expenses on their own. Lastly, I want to point out this figure right there. That shows that right at the end of September, treatment services had excess revenues of $689,000. Does anyone have any questions about this historical data? Yes. Could you use your microphone, please?
Under funding, after where you see the list, Medicaid, Medicare, what's that next line, the next column that has 346.9778, then it goes 346.9774. What is that column for?
Yeah, please.
That was a hidden column.
It should have
That
been
was
hidden.
opened up. That's just our revenue coding structure
Okay.
on our financials. So
I'm paying
it's
attention.
the different types of funding streams.
Okay.
Yeah, so accounting
Thank
numbers.
you. Thank you for that. I appreciate that. Yes, Commissioner Cooney.
So as we look at the year-to-date for 9 months in 2024, knowing how, funding and payments work, I mean, they don't all come in at the same time. So, so saying that that's, right now we're at a $700,000 positive. I don't know, I mean, I couldn't say that that is true because when you get funding in versus, and where are accruals, sorry, talking accounting speak, to know if this is cash basis versus is this truly accrual basis, to know where we're really at. So I just am
Yes.
asking and
So,
cautioning that it's probably
absolutely.
not on accrual basis.
In treatment services, we bill for services weekly. And so it's not like our grant-funded programs. Like sometimes Kim will come up here and she'll say, this looks better than it should because we haven't made the payments out yet or we haven't received the grants in. Treatment services, they bill every week. And so their revenues are constantly coming in, constantly. And I don't know what our AR right now is. Because I was, as soon as I said that, I was like, if I were her, I'd want to know what our accounts receivable was. Yeah.
It's updated every month, a new AR. So this reflects all receipts plus outstanding billables that were earned in that month. And then the next month, we will revert back to the milestone. So it's modified.
So, but then are there other expenses that are like quarterly or, I guess that's what I'm just trying to make sure that, like on the building costs and all of that everything would be included in that number.
Yeah.
I would say they're the most accurate on a month-to-month basis. There's not a lot of, we do pay rent, it's due by the 1st, so we pay that like on the last day of the month. So that's consistent, but all the other expenses are your salaries, benefits paid. So there's a few that might be lagged, but for the most part, we don't have a lot of delayed billings. So we do post and anticipate what is the outstanding AR. So this is a pretty accurate picture. What we don't know is if what we build, if there's anything to be rejected or needs to be resent. So there could be some of those, but those would be modified the following month and reflected in the new AR.
Any other questions on the historical data? Yes.
Sorry, do we know, looking at the 2022 and 2023 actuals, do we know why the treatment costs per client jumped from 45.31 to 58.95.
I'm sorry, my copy, I didn't think about having a readable copy for myself.
Okay.
And,
So I'll just tell you, so it has the unduplicated clients served, 1,639, and then it has the treatment cost per client. And then in 2023, the treatment cost per client. So the unduplicated clients served went down about 45 people, and then, but the treatment cost per person jumped about $1,300. And so I'm just wondering why that is. That's a considerable jump compared to the previous years that only went up about $200 each year.
so I apologize, I am presenting the certified public accountant's work, and I don't know it intimately at that depth to be able to say so. I
Does
could go to
Kim
the
know?
Excels.
Well,
I could
I'm
go
looking
to-
at, there was an increase in salary and benefits from 22 to 23. So that could have played a part in increased cost per client, right? Is that what you're getting at? And a few fewer clients, but not too many.
And I'm going to venture to guess too, that's part of the new building costs, because I think that 2023 is when they moved.
That's
into
what
the
I
new
was
building.
wondering.
It went
Does
up by
that-
500,000 for the building cost.
That figures
Yeah.
into that number.
I would assume so, but I don't know.
And I do apologize, I could go into the Excel spreadsheet and see what her formula is.
No, the indirects went up and the services line, which is the building lease, right? So that makes sense as well.
Yes.
I don't really think, I suppose, but just looking at the unduplicated for 24 right now, being unduplicated, new clients, I assume they're going to be monthly, so I would imagine that number will be fairly steady, even though we're only in September. You can see the new average will be down. I'm just curious how the counters, the number of clients compared to the average.
So let me try to explain unduplicated clients and the clients served per week. So with an opioid treatment program, you have a lot of people that make an attempt to get into the services. They start the services, and then something happens in their life and it shoots them off back into their addiction. And so then they'll come back again and try again. That's a very common process when you're trying to recover from opioid addiction. And so the unduplicated counts include everyone that we've provided services to. And the weekly count that we're showing, the average weekly count, is right now, it's what, 57? It's 57 different from last year. And last year was one of our lowest count years. And these are all averages.
But I guess that makes sense, but I guess that also assumes that there are potentially 400 or so that should go to the account and fail in the next 3 months or so. Years. So it just seems like a big jump, or actually a reduction from the past. Is that a trend, or we're gonna catch up?
What's-
History.
Yeah, it's missing 3 months. It's missing 3 months, that last column. So that's part of what you're seeing. Yeah, it's not a full 12 months. So,
So, my question, when we're saying our target is 1,400, then are you saying the target is 1,400 of unduplicated clients served, or
No.
1,400 on the average
Yeah,
weekly
weekly.
basis?
That would be our target, is to increase our weekly number of clients to 1,400.
So if, I'm just doing kind of quick math here, so if we're looking at 2024, if we're at 981 and we add in the 146 that are not being, that have been turned away, then we'd be looking to add an additional 273 clients a week to get to the 1,400.
I can show you the next slides with the pro forma and how she determined,
Okay, thank you.
if that will help. Okay. So Julie created 3 pro forma models for you to compare and evaluate. The first is based on input from treatment services and used the 2024 annualized. So what she did is she took that incomplete 9 months and estimated what it's going to be at the end of the year. So she annualized the 2024 costs and 2025 salary benefit budget. The second added in, the second model had both those things, but it added in the 2024 opioid treatment and mental health assessments. And the third used the opioid treatment program and the mental health assessment numbers from 2022, which were the highest of all of the years of the data. And models 2 and 3 are meant to help the board evaluate the information in model 1 based on past actual results. So this first, the goal in all 3 models is to increase the weekly average of clients that are being served to 1,400. This model includes Saturday hours, 18 new counselors, 2 new RNs, fill those 2 mental health vacancies, and 1 receptionist. The salary and benefits are based on 2025 budgeted amounts and increase. The revenue was not forecasted. It is unknown what type of funding new patients would come, what type of funding the new patients would be coming with, and there was not adequate time to analyze this data before the meeting. So you should have a spreadsheet like that looks like this, that has all 3 of the models side by side. So let us know if your book doesn't have the models side by side. So this particular model, and our 2025 proposed budget is $10,233,000 for treatment services overall. And this model shows an increase. This number over here is the increase, the total increase to achieve the goal of 1,400 average clients served per week. And I know this is really hard not having Julie here to present these pro formas. I can see questions. I can try to, yeah.
Sorry, did you say that the budget we just approved
Yes,
for 2025 treatment services is 10.2 million?
yes.
In terms of revenue, or expenses?
Expense and revenue, yes.
Okay, balanced budget.
Mm-hmm.
And this one would be 12.7. It'd be an increase of like 2.5 or something. I don't do my math very well. But on the right-hand column, it says 4,352,000. So what is that number?
It's It's a really good question. And again, I apologize. Did she say in our meeting yesterday?
Yeah.
Because that would only be
With
like a
the-
2.5 million.
We're at 10 million, like what we just passed. So, but there's additional staffing that Alicia mentioned that would also increase. So the budget would have to go up by the 12,762,000. And then that's the salary, and then the increase in FTE costs. And so, you're correct, it would be a $2 million. I think the next few slides will show what the increase is with other scenarios. But increasing to 1,400 would bring in more clients, more revenue, but also we would have more staffing. So minus 2.5, what's this for?
So this is, so that's confusing me. And then notice that she has.
Well, it was 10.2 minus 12. Anyway, yeah.
So I don't know what that is compared to this. It just
Is
shows
that-
2024's budget. Because that would make sense, because 2024's budget plus that is this. This next one?
This vehicle.
Yeah, yeah. Go to the next one. Go into the next one.
Yeah, that was.
That's what we're
The
thinking.
first one is the 24, and then the next two are the scenarios. So the Performa one is 24's budget with 25's projected expenses. And then the 2 and 3 are the options based on.
Except the pro forma one, I mean, total treatment services expenses of 12,000,000.7, which is different than 10.2, so.
That, I think that would be based on the 1,400.
Okay, so,
If they were able to achieve 1,400 clients
so,
with the
so
same
Mr.
staff.
Chair,
No, more
I
stuff.
want to state that this is all new information that we did request, but we are not going to be able to make a decision today on this, because I think we need to understand, we are just adopted a budget at the 10.2 level, and now we're getting additional information of how we're wanting to change what we just approved today, which I'm having a hard time understanding. We should be, that should be our starting point, is the budget that was requested by the department for us to approve today, which we did. To then say we're gonna now change, we haven't gotten the information as how we're changing. Again, if I go back and look at, if we're looking at average weekly, you know, again, we'd be looking to add another 273 people when we've been declining over the last 2 years. So I can't, I apologize, but I will not be able to make a decision today.
Councilman Cathcart.
Yeah, I would agree. I mean, just based on all the new information, and would love to hear probably from Julie, you know, as well in understanding her process. And just, yeah, we need more information.
And I think we'll need to hear from Misty as well.
And she is out on a leave, extended leave.
Patricia?
I think, echo what you're saying. I think but this kind of gets to the crux of sort of the problem in trying to solve or make a decision with all of this moving forward. Because of, and my feeling before coming in here is that, and I'd like to hear Michelle's feedback about this, it seems to me that the RCW allows to seek other funding elsewhere to support these programs. It's clear that the program is really important and really critical, and the feedback is very meaningful, and that, you know, people like it and feel stable there. But we also have to deal with the RCW and the actual dollars. And this is sort of confusing to be looking at the 10 million and then the 12, 10.2, then 12.7, then adding an increase onto that as well for the next year. So those are all pretty significant increases, and we haven't heard from the program director about how those costs are going to be met internally. What are they just going to ask for more funds, and then we're supposed to figure out how to do that or what? So I just wanted to make that comment.
So, sorry.
Did you want to?
Well, there's two things that are important to remember with this request that was given to us. And one is that these are not requests for changing this year's budget. These are just like guesses of how much would it cost to increase our services so that we did have the staff and the ability to pay for expanding our services to provide care to 1,400 people on a regular basis, a weekly average of 1,400. And so in no way were we coming in with an asking to change the budget. These were just guesses on, that's what a pro forma is. It's a forecast of trying to figure out what would it cost us if we went forward and tried to do this and meet this goal. And the second thing is that the way that treatment services makes its money is it gets paid for the services provided to each client. It's a fee-for-service program. So just like any other healthcare provider, they come in, they receive a service, and we bill for that service for whatever they received that day. So I think, did Commissioner Waldrop and then?
Oh, yeah,
we'll
I
go
just
with
was going to
Councilman?
say, I think what you did here was, thank you for following up on all the hard work. And I'm sorry that certain people couldn't be here today, so I do
Yeah.
agree. It's a lot to dig into. We'll have lots of questions. But what I appreciate that the idea was to do the exercise of actually doing a real business plan to understand what are your current costs, how many realistically can you serve per, how many assessments can you realistically do, how many more staff would it take, right? So this was like really an exercise, which I
Yes.
think was really important for treatment services and the health district to do, to just better understand this line of business that you have. And hopefully, whether or not it's 1,400 or 1,200 or whatever the number could or might be, this is the type of exercise you would go through to see, do you have the money to be able to invest in staffing up to do different numbers, right? So it's really just an exercise.
Right.
And the 1,400
exactly.
was just a number that you guys chose.
Yeah, it
Okay.
was Misty and her team.
But it could have been 1,200, it could have been
Right.
1,300. That was just the
Exactly.
number. Okay.
Yeah, and I think that 1,400 was based on, like, we've turned away 146, and, somewhere around 300 people for the year, but we didn't start counting that until July 1st. So, yes, Councilman Cathcart.
Yeah, I think the other part of the conversation that would be good to have, if assuming this gets deferred and there's more time to discuss it, is that the business end of, so this is saying that we're going to increase from basically 59.5 FTEs to 83.8 or 86.7. So how are we going to recruit them? How quickly would they come on? Is there the cash up front to hire them and bring them on? Just how is all those pieces going to come together, and what would be the timeline? If the board said today, okay, let's pursue this, how long would it take to do it? And then big picture in the conversation, why we're having this conversation, how would that compare to, some of the other entities that you've been talking to as well? So I think that's other good information for us to get.
And I don't know how much information I can get from other entities like this. So I can try, but.
I just want to note that there are grants and things in here as well in the funding, not just Medicaid and Medicare and fees.
Can I ask one question? So speaking of, on that note, the substance abuse block grant, I know that comes through the county behavioral health community services. Is that what's used for kind of sliding scale when folks, is that used to kind of fill in gaps when someone may not have insurance or they may not be eligible for Medicaid? That's kind of like the sliding scale piece. How does that work with the county?
Well, they give us, I can't remember the exact name of it. Our financial reports use different names than what we call.
I was just wondering if,
every
like,
day.
can that go up and down depending on the needs of the clients?
Well, they gave us a certain amount of money that if they didn't meet the sliding fee scale, but they were just slightly over the sliding fee scale, that we could use those funds to help them stay on the program. That funding expired June 30th. And so we don't have it anymore and we won't get it again. We also have the CJTA grant contract. I don't know which it's called on here, but that's for the dosing that we do in the jail. And so we're reimbursed based on the number of people that we dose in the jail. And some of them have ended, and I believe there's notes that say, you know, that they've ended and it was one-time funding.
Yeah, I would just, I'll make a motion to defer consideration of this item to the December 6th Board of Health.
I believe it's
I think is it the 5th, just
Ah,
for the record?
Thank you, thank you.
Okay.
Second.
We have a motion and a second to defer item 7D until the December 5th Board of Health meeting.
Just one quick thought on that. If there's an opportunity for the Finance Committee, Budget Committee to maybe just try to capture some of the likely questions and things in advance so that we make sure we can get all the most relevant information at that board meeting, or between now and then at least.
Okay.
I'm happy as the chair to do that, but I'd also recommend that any questions you guys might have to be reaching out to, so that
Yeah.
way we can accumulate all those and reach out to Dr. Thompson, and then we can talk about the finance committee.
Great point. Patricia?
Oh, sorry, HR isn't in here. I can let you know when she's due back.
That might be helpful for our finance committee. She's not going to be here. Any questions?
She will not be back before our December 5th meeting.
And maybe there's someone else who's
April.
acting in charge.
Yep, April Pinckney.
Okay. Any other comments?
Oh, I was just gonna say that one thing that makes it, thank you for doing the work with bringing in an expert to put together this. And I know I'll have more questions, which we can talk about and prepare for. But realistically, it would also be good to look at, you know, what would a realistic ramp up actually look like? Because obviously we don't have the funds in the bank to go from, you know, like as Mr. Cathcart was saying, from here to here. So if there was some financial folks or this gal who did the pro forma work could be available to ask different scenarios, that would be great. But I appreciate the 3 scenarios that were put together. realistically, like, a change would take multiple years and require like a, you know, a planning process around, to get to that type of number. So unless we magically have, you know, a couple $1 million in the bank, which I don't think we do. So, but thank you so much for making the effort. And I do think that although this process has had ups and downs, and I know people get concerned about looking at, you know, what we could do with treatment services differently, I do think going through this process is really important. We, like, I'm looking to Dr. Likowski May, but like if you are running a clinic, it's really important to know how much it's costing you per person and how maybe there's efficiencies to serve more people. What are the key positions that need to be staffed up to be able to do more assessments? So I'm excited to just get more of that information, and hopefully that treatment services is excited to look at things maybe differently than in the past. So thank you for your work.
Okay, we do have a motion and a second to delay action on item 7D until the December 5th board meeting. All in favor say aye.
Aye.
Aye. Motion passes unanimously. Okay, that brings us to item 7E, and this is resolution 2411. This is amending a resolution 1601. I'm going to, looks like it has Councilmember Cathcart queued up to present on this.
Yep.
Okay.
Yeah, real quick. So this has been bantied about for the last several months, but the policy committee's taken a look at it at our last 2 meetings. The backstory is a couple of constituents in my council district are looking to try to open a private club where cigar smoking would be allowed. This has been done in other jurisdictions in the state, elsewhere, and so just making sure that there wasn't any sort of gotchas, I guess, just trying to clarify the resolution that addresses the smoking in public places. And specifically what this does is, and there's some technical stuff in terms of how we're adopting it, but basically what it does is it identifies, you know, what a private club is, so monthly or annual fee is required, specifies that those individuals as a part of that club cannot bring more than 3 non-member guests in, so that it is not a public venue. That's the emphasis, is that it does not become a public venue. And then also it redefines employee to make sure to exclude basically voluntary actions by club members to clean up after themselves or to clean up the space around them. And that's essentially what this does. Happy to answer questions if we've got them. Effectively, what we're doing is adopting a separate resolution that amends the original resolution so that that resolution number does not change and affect signage and things like that out in the community. So that's the reason why there's sort of a separate resolution that adopts the base change.
Any questions? Mr. Waldron.
Well, thanks for working on this. I know it's taken a while to get in front of us, so I appreciate your work, Councilmember Cathcart. How has, in the other jurisdictions that you're talking about across the state where they've had these, they've made an allowance for these private clubs, has it been easy to regulate the idea of, oh, you can't bring more than 3 people in? Like, how has that gone in other communities?
On the limits on numbers of folks you can bring with you, I'm not sure how they've regulated that aspect of
and
it.
Who regulates that? Is it the health district?
Presumably it would be the health district, but again, I think it's generally complaint based, and so that's when they would come in and regulate.
Dr. Thompson?
Thank you.
Yeah.
Okay, thank you. Commissioner CUNY.
And typically in member organizations like that, it's the membership that is self-regulating a lot of that.
And the only other thing I would add is there is a modest capacity limit, so even if they really wanted to, they would be in violation of their own capacity. So it'd be a fire marshal issue.
Okay. Any further, Dr. Bukowski may? And can you direct us, which page, which language is it you're referring to? Got it. Yep, the red line and the blue line mark, yep.
Yeah.
So the intent, as I understand it, is that if you can only bring 3 or less, then you are not a public place. But if the members can bring more than 3, then it's a public place. That's the intent. So the key is to just pick which phrase, or select the phrase that is consistent with that intent. So public place would mean a place where you can have 3 or more non-member guests would put you into, or 4 or more, whatever we decide, would put you into the public place definition.
So you think we should change the language?
Yeah, I think when we went to no more than 3, I think we really want to have 3 or more, unless the board decides that you want a different number than 3, if you want 4 or whatever it is. But I think that's the correct way to define when you're pushed into the definition of a public place.
Can I ask for clarity? So as written, what I'm looking here says where a monthly annual fee is required and at which no more than 3 non-member guests per member. That, you don't like that language, or that is the language you like? Or you say, are you recommending a different language than what's written here?
So, yes, but only slightly. So if
Okay.
you start at the beginning, public place also means, okay, and includes a place where a fee is charged and 3 or more non-member guests per member are present or permitted. I think in order to track the entire paragraph, we need to fix the language.
I get it. I get it now. I get it now. This is defining a public place. This is essentially, okay, I track with you now. Got it.
We went back and forth a
Okay.
lot, so we knew what we wanted to say. We just want to make sure we got there.
Understood. Councilman Cathcart?
Yeah, I would make a motion that we amend this to clarify the language as presented by.
Okay, so, trying to think, do we want to save amendments till the very end, till we're ready to adopt? We'll adopt amendments, and then if the support is there, we'll adopt the whole document as amended at that point. So, are there any other items that anybody has concerns as far as language? Okay.
I just had a question about,
Oh,
sorry, I thought I had it on. So can you just remind me, I know you've briefed us on the employee piece, Mr. Cathcart. So does this club not have any employees then? That's what you're trying to clarify. There's no employees here. People come, they bring a couple friends, and there's no one that is cleaning up after them. So therefore, there's no violation of like employee and smoke in public places.
The
Okay.
club rule would stipulate you can't come back to yourself, you're free to leave. There's no control.
Okay, thank you.
I have a question. So I received a call from somebody and they were looking at number 2, so 3, number 2, so the paragraph before that one, and I asked Michelle about this. They were discussing the last line that was removed, a private facility shall not be considered to be a public smoking lounge. And did you discuss that? Can you tell me
Based on
more
feedback
about that?
from council, it was determined that that wasn't language that could be inserted based on RCW. So I don't know if you want to clarify that.
Sure. The paragraph 3A2, second full paragraph, that is taken directly from the RCW definition. And so it was not appropriate or available for this body to change the RCW and make it more expansive than the state law. Which is why we took that language out.
Can it also be sort of, I mean, I was trying to figure it out in my mind, isn't it sort of assumed that what they're saying conforms already with the state law? I think what they're trying to do is keep it in conformance with the mechanical code. And I called and talked to the deputy fire chief a little bit about it, just to see what he thought about it. What he said was that when they go through their process, they would be going and making sure that everything was in conformance with the RCWs anyway. But I also discussed with him that there can sometimes be sort of a chilling effect where something is interpreted to be not in conformance with the mechanical code that actually is, and that might create some kinds of problems. So I'm just wanting to make sure that I'm.
And I think that was part of the goal of that language too, was just to clarify for not just for the community's sake, but for that too, but also for other entities, to clarify that this is kind of not public, it's treated a little bit differently than other but again, we weren't able to insert it that way. We'd like to do, but
Well, I think you stated that we could put it in there if we wanted to, but that it isn't the way that the paragraph was originally written. Is that how I understood what you said yesterday?
No,
Or
what I said is, the paragraph that's in there is a direct quote of the state law, and we as a local health jurisdiction can't revise that state law to make it more expansive than what the state law requires.
And does that statement make it more expansive?
It does. It
Can
does.
you explain how that is?
Sure, I'll try. So we have put a very narrow exception for a place that is neither a public place nor has any employees, paid or unpaid otherwise, because you're just picking up after yourself, is my understanding of the business model. But if we put in language that says that a public place doesn't include any private club, that's broader than that very narrow exception that we created in the proposed resolution.
Well, and the private clubs have a totally different set of laws, like country clubs or whatever have different.
Yeah, but the smoking in public places law doesn't always treat them any differently, so.
Well,
and I can't speak to
they're
the mechanical
restricted.
code.
They're restricted more than this would be, since there's no employees there. So the problem is the employees, from what I read. If employees are there, then they're being exposed to secondhand smoke. So that's why if there are no employees, then they can do it. And when it's like a country club or whatever, obviously there are employees
Correct.
there and so on. So anyway, okay, well, I want to make sure that I'm looking at that fully.
Any additional questions? Okay, so we'll start. Councilman Cathcart, you had a motion for an amendment.
yeah, I'll again make the motion that we amend based on the language feedback that alters that sentence about 3 or more to conform with what legal had advised.
Okay, is there a second for the amendment?
Second.
Okay, so we have a motion and a second to amend that line under section 3A2 in the third paragraph to make that paragraph flow more, addressing the number of three. Of three people, no more than 3, keeping that consistent, just rewording that to reflect what legal was recommending. All in favor, say aye.
Aye.
Aye. That motion passes unanimously. So now this brings us to, is there a motion to adopt Resolution 2411, which will amend Resolution 1601 as amended?
I will so move as amended.
Second.
We have a motion and a second. Any further discussion? All in favor, say aye.
Aye.
Aye. The motion passes unanimously. Okay. That moves us on to this moves us on to our reports. Okay. Administrative Officer report. Dr. Thompson?
I'm sorry, I don't have one.
Okay. No problem. Then we will move on to financial report. Kim?
Okay, just give a brief report on September's financials in your packet. So we're 3/4 of the way through the year, so it would be at 75%, would be our target. As far as expenses, we're under that 75%. We're at 66% of our budget. And then our revenue is at 72.1, so we're actually, this time, revenues exceeding expenses, both under the 75% of the budget year to date, though. The overall fund balance increase as of that point in time in September is showing a surplus of $2.9 million. Significant reason for that is Foundational Public Health Services of $3 million was received in July, and the revenue covers expenditures through the month of December. So we had advance payment for those. And then also the public health appropriations from the state of Washington, $1,438,000 has also been received, and we will be using those dollars for expenses through December. And then one other item to note is on our services. We have our ESIP program, early intervention for infants and toddlers, and those are large payments to 6 different providers, and they're a month behind in their billing, or in the payments. We had a payment for September made in October, and that was just because of a delay in the contracts fully being executed on both sides by the parties. So if I'd had those expenditures in there, we wouldn't be as high as the 3.9 surplus. So it's literally just a snapshot of September. But that brings us to total reserves at $20 million, unassigned reserves at 28%, so we're well above that 20% goal. But I do expect both of those to go down by the end of the year.
Any questions for Kim? All right, thank you. Okay, this brings us to our health officer report. Dr. V.
Good afternoon, everyone. I do have a number of things, so I'll try to go quickly since I know that we're against the clock right now. So I'll give you the highlights for pretty much everything. So I have a few things I want to just for awareness, and I'll try to move those quickly. So I think we've all heard about the avian influenza, the HPI, is moving around. And one of the issues, this is just a summary of the impact in the country thus far. Significant impact, pretty much full spectrum of everything from commercial to house, flocks and other animals, and these are just the high-level numbers for all. If you look at the distribution around the country for commercial flocks, and these are birds specifically, it's pretty much widely distributed with the exception of a couple of states. So it's something that we're seeing all over. And what one of the concerns that we have identified over the last few months is transmission from infected animals to humans. We actually have, as of this morning, 39 total reported human cases in the United States. And the breakdown is by state. California has the largest. They're a very large agricultural state. Washington is the third. Colorado is the second. As you know, in Washington State has been mainly concentrated in Franklin County, and I have a quick slide on that one. But at this point in time, a couple of things are important to remember. Thus far, all we have is evidence transmission from infected animals to humans. We don't have evidence of transmission from human to human. Of all the cases that have been identified, there's only one in Missouri a few months ago in which we could not establish exposure. but at this point in time, it is the theory still stands that is from animal to human as opposed to human to human. This is some information that we've been tracking from Franklin County. Our team here has been engaged in that conversation. This is just to give you some idea. In October the 11th, there was some preliminary testing on commercial flock. The Department of Health was notified. Symptomatic employees restarted reporting within a week or so, which is where these numbers come from. Testing has been confirmed at the CDC. This was included in the previous slide. And thus far, we have not seen anything on this side of the mountains. We do know that there's at least one commercial small flock in Spokane, in which were animals that were tested positive. It was about 80 chickens, I think, give or take. So far we have not seen anything beyond that in the eastern part of the state. Now, the most important lesson for all of us is the risk of transmission from human to human. It has not been established. Risk of transmission from animals to humans is low. You have to be within typically some of these businesses that handle animals or have a backyard flock. And one of the most important things is keep the species separate. We were alerted that yesterday there was a pig in Oregon that tested positive. It's about 5 or 8 of them right now. So we've seen transmission between species already. So if you have backyard animals, you see a dead bird or a dead animal, please report it. Keep your pets away from it. And if you do have chickens, don't mix your chickens with your cattle or your cattle with your pigs, et cetera, et cetera, et cetera. Yes, sir.
Just human to human, how, I mean, how quickly can this spread relative to other things?
Well, right now we don't have transmission from human to human at this point in time, so we don't have a vehicle, a pattern, or a transmission speed. What we have is animal to human and animal to animal, and that we know and have been able to document the incubation periods and so on and so forth, but no human to human, and ideally, let's hope that it stays no human to human, although there was a case last night in Vietnam of H5N1, which is a different type of animal flu. So we're going to track that starting today.
Okay.
Good question. Yes.
Can your pets get this off of your shoes?
That's an interesting question. I think the exposures tends to be consistent and significant load for transmission. I don't know if just walking into your house from your backyard, but what I will suggest, just for the sake of any communicable disease, if you do have soiled shoes or something, well, leave them outside or clean them. Don't bring them to the house where you have pets or others. So that will be, if you look at the list of precautions that are being recommended for farm workers, one of them has to do with the appropriate treatment of clothing, shoes, et cetera, et cetera, et cetera, so you're not moving things around. That's a good question. And actually, both the CDC and the Department of Health have some recommendations for those that have animals to look at, which will be good to read. Okay. Good question. Okay, so with that, I'm going to move on to the next one, and I have a lot more information happy to share, but I'm trying to move quickly. So we've talked about pertussis before, and I'm sure you've seen the news. We do know that pertussis is moving around the state. Right now in the country, we have about 1,008 confirmed and probable cases statewide, in the state of Washington, as compared to about 45. We have about 90-something. I'm going to show you that slide in a second. We talked about this a few months ago. The risk is typically children, infants less than 1 year, pregnant women, and those that are exposed to any of those. What we have in Spokane is these are epi curve, and as you can tell, we're seeing an increase as we go from September to October. It's spread around the community fairly evenly. There's no pockets. There's no definitive areas. When you look at school-age children, it's a long list of schools, all of them with 1 or 2 cases. So there's no geographical pattern. So the best way to look at this is pretty much all over the community. probably the best way to look at it, not isolated to any particular population, segment population, or demographic group, pretty much everywhere. When you look at the rate per 100,000 population, seems low compared to the higher parts of the state, which is like 70 or 50. And that is because we didn't have a lot before, so when you aggregate it over the year, it decreases that rate. But if we were to do the same calculation, starting, I don't know, mid-September, it would be extremely high. Just as you look at the numbers, just to explain why that number doesn't seem as impressive as some of your counties where it's like 74 per 100,000, okay? So we have been, the team has been in communication with, constant communication with schools, childcare, et cetera, et cetera, et cetera. We are doing a lot of prophylaxis of people in households that are at risk that we do have the standing orders for. And the distribution that we have seen, not uncommon. You can tell that as of September, we started to go sky high on 0 to 4 years of age, 10 to 19, and a little bit on those that are slightly older. So none of this is unheard of, but it does highlight the fact that we're on an upward trend. So you are probably going to hear more from us about that. We have been in communication with providers multiple times, and more than likely we'll have additional communication to make sure that is in the differential diagnosis, and also that those that have been exposed can get prophylactic therapy. Okay. So with that, I'm going to move on to the next item on the agenda, which is listeria. And I'm sure everybody has seen the news that several prepackaged products were, by now, is I think like 1 million pounds of food or something. I can't remember how big it is. But it all started back in July with prepackaged meat products. By now, actually, this has moved. And if you go to the FDA, Department of Agriculture, they actually have pictures and listings of all of the items that have been recalled by now, which is fairly broad. It's not just cured meats. It's everything from waffles to salads to, I mean, it's an extremely long list of issues. Now, listeria, typically, many people will have no symptoms, but if you are in certain age groups and or certain pre-existing conditions can be lethal. We've seen a number of hospitalizations and at least one mortality. This is where no, that's a national. So, now, one of the issues is we don't really know how many people have been infected because a lot of people will be asymptomatic. But we do know that based on the distribution of all of the products, it's a fairly significant exposure at a national level. Now, these are the states in which we have seen the concentration. A lot of it started more on the east. If you think about it, there was a plant over there, but I think that has been traced to Colorado, and actually, as of yesterday, I think the FDA has a local onion grower under investigation. No, actually, that's for E. coli, but I think it's been traced back to the plants that manufacture all of those products that are in the center and the eastern part of the country. And one of the things that is significant is mortality. As you can tell, the highest level of mortality has been seen pretty much in eastern seaboard. Now, this is what we need to be aware of. If you're pregnant, age 65, or have any pre-existing conditions that weaken your immune system, you need to be mindful of. So if you have any other symptoms that go along with that, please contact your provider. If you recall, last year in August, we had to do some work because a place in Tacoma had a listeria outbreak. And the interesting thing about this bacteria is that it survives in cold spaces, you know, refrigerators, yogurt machines, and all of these other things. So you do have to do a fairly good decontamination with temperature up to 165 or steaming hot. 165, if you cook, that's the cooking temperature for chicken, for example, just to give you a comparison. So E. coli. It's been an interesting time for the food industry. So there was a report of illness after consuming quarter pounders, certain McDonald's. And as the investigation took place, as of the last few days, has been pinpointed to onions in the quarter pounders that were contaminated, and that's why a distributor has stopped distributing onions, and now, as of last night, farm in somewhere in Washington, they just not close which one or where, is under investigation because they may be a provider of onions to that other facility. Anyway, so it's caused a significant amount of issue. As you can imagine, McDonald's is one of the largest chains in the world, so good news is it's been somewhat geographically contained. Now, the issue is that this particular bacteria can produce a toxin, and the toxin can be quite significant depending on your age and your immune system, all the way to causing issues like renal failure, disseminated vascular coagulation, a whole bunch of other things. So it's not just you don't feel good and have diarrhea. It could be more significant than that, which is why it's very, very important that anybody that develops symptoms and may have consumed one of these products in any of the areas in which was allocated, that they seek medical attention. I know when you look at the cases, there's one in Washington, but the one in Washington was traced back to having had McDonald's in Colorado before coming back here. So anyway, this is where we see the bulk of the cases, and of course we're there because we have a case, but it was traced back to the distributor that is in Colorado, and there's a tie to Washington now. So it is important to note that if you have diarrhea and fever, that's a combination, more than 3 days, not improving, if you have bloody diarrhea, if it's 1 day, please contact your provider, because not being much, I copied that from someone, I would have said not decrease urination, but that's good enough. So if you have any of the symptoms, please contact your provider so you can get medical attention, because it can be treated, it's just you have to be aware of what it is. And from what I understand, McDonald's has stopped distribution of these products in all the states that I mentioned, and has indefinitely ceased their agreement with the producer, Taylor Farms, in terms of onions. They're not getting onions from them anymore, so they're trying to remedy the issue. Now, the good news is it wasn't some of the other products, so it was narrowly defined in just one of the items that goes in the burger, because you can imagine those burgers have a lot of stuff. So if it was a lot of, it gets even more complicated. So that's a silver lining behind that one. Now we go from that one to hemorrhagic fever. Marburg, remember we talked about it in the last year, because there were a number of cases in Rwanda, and we have seen that has continued to increase. This Marburg virus disease can be significant hemorrhagic disease with what is called a 24% fatality rate, which is fairly high. Typically, DIC, coagulopathies, and an impairment and bleeding, which is the reason what we're talking about. Now, why we're talking about it here now, and this is the history behind it, which I have shared with you before, is because, and that's the bat, the Egyptian fruit bat, which is a reservoir. Remember that picture I showed last time we were here. But the reason why we have bring that to your attention is because as of mid-October, there is more of a surveillance for returning people coming from Rwanda, and there's some quarantine isolation that is occurring. It's being handled across the country in 1, 2, 3, Dulles, New York, JFK, and O'Hare international airports. There's points of contact, so the CDC will be tracking that. We're part of the information, so we know that is happening. The rationale for that is if it does come into the country, immediate isolation is required. Now, the good news, and I'm going to give a shout out to our friends at Sacred Heart, for this type of disease, you need what it's called a special pathogen treatment center or special pathogens unit. And if you look at the map, we happen to have one of those in here at Sacred Heart, which is a great place. Our team works with them very closely. They do a magnificent job. So in the event that we were to have a disease such as Marburg virus, which if you recall, at the beginning of COVID, that's where COVID patients in Washington were going to our special pathogens unit. So I just wanted to give them a shout out because they do a magnificent job, and most people don't know that we have this. Okay, and if you look at the map, it's not like there's one in every corner. There's just a few of them. Anyway, so with that, I'm going to move on, and I'm going to give you a quick update. I have about 5 slides, but I'm only going to use 2 to save you some time. So this is part of the update. We had a fentanyl roundtable meeting yesterday, and this part of the update, we've seen this spike in the last month or so. So we're trying to investigate what is causing that. And there's a lot of theories right now. We don't have the bottom line as of the point yet, but this was one of the 3, we had 3 significant updates yesterday. But something I wanted to highlight is a collaboration that is resulting in a good outcome for the community, and has to do with the contractual relationship with Three Bears Consulting. So I want to take a step back. When I talked to you about the fentanyl roundtable, I mentioned the Restoration Center, which some of you have been to in San Antonio, which has been mentioned as one of the best models. Now, they have a campus. You need to have a campus per se, as long as you have coordination between services. So the folks that put that together, run that very successfully, now have a consulting group. They're going around the country helping communities address these issues. So I was introduced to them by the Citizens for a Safe Spokane that sit at the round table. And through the Citizens for a Safe Spokane and Three Bears, I was introduced to the Race Reading Foundation, which runs the Spokane Alliance for Fentanyl Litigation. And one of the things that we talked about was the fact that we did an assessment, a community assessment of the services that are available, but that doesn't tell us effectiveness or coordination. So Race Reading Foundation, and thank you to them, they actually have engaged Three Bears to work in Spokane County and do a really deep dive on behavioral mental health and its corollary of substance use for resources. And the goal is to determine not only what we have, but the effectiveness, the coordination, and the gaps, and come back with recommendations for the community, which they've done in a couple of other communities. So I want to say thank you to Race Redeem, because they are paying for that. I don't have a budget on the fentanyl roundtable, just for the record. So I'm very glad that they're, and I know that how much it costs, so I can tell you it's fairly expensive. So, yes? Yeah. I mean, yes. Never, yeah. Always yes. And I can give you a slide. Okay. And I have a few more slides from them, but I just wanted to bring that up. And probably the most important thing, the assessment has started. They've been working in the community for the last month and a half or two, talking to a lot of people, getting a lot of data. And if you have any recommendations as to anyone that they should talk to get additional information, please let me know, because we can certainly connect you with them through Race Routine or directly with Carla Ramirez, who's managing the project for Spokane. So I'm going to stop here and see if there are any questions. Oh, sorry, I had one more update, but since our emergency preparedness folks are here, I'm not going to say very much, other than they're engaged in a whole bunch of things that are very, very important on top of it. So I'm sure they'll talk more about it, but everything from the IV solution shortage, which is still ongoing, to concerns about what happens around elections with potential powders and wildfire and smoke and special pathogens, etc. They're engaged with it. So I was going to give them a shout out, but since they're here, I will not, because they're doing a great job and they can talk about it a lot more than I can. But the reason why I bring that up is because there's a lot of things that the team is doing behind the scenes that you may not be aware of that are very important to the community, that may be quietly out there, but without those, things wouldn't happen. So, questions?
Any questions? No? All right. Thank you,
Thank
Dr. V.
I'm catching up for not having a report last month, so there.
No, it was good stuff. Good stuff. Okay, that brings us to our agency reports. And the first one we have here is the Health Equity Annual Report.
Okay, hello everyone. My name is Devin Bell. I use she, her pronouns, and I'm the Health Equity Manager here at Spokane Regional Health District. And today I'm just here to share about our 2024 Health Equity Report. Board of Health members, you can find it in your packet, and folks who may be joining us online, you can find it there. But before I dive into the report, I do want to start with a little bit of base setting, because I know health equity tends to be a word we hear a lot. And so I always like to just use some time to really talk about like what we mean when we use the words health, equity, and equity. So you'll see on the slide here, we as Spokane Regional Health District define equity as everyone getting what they need to survive or succeed, whether that be access to opportunity, networks, resources, or supports. And it's based on where they are and where they want to go. So we recognize that not everybody starts at the same place in life, and everybody has different goals. And then in the context of health, for health equity, we define that as the state in which everyone has a fair and just opportunity to attain their highest level of health. So again, recognizing that what that highest level of health looks like may be different from person to person. And then within the context of public health, we use the 10 essential public health services as a framing for all the work that we do. You'll see on this slide, the three large areas of work we do are assessment, policy development, and assurance. And the base of each and every one of those tasks is equity. It's really centered in every single thing that we do. And here at Spokane Regional Health District, we even go a step further. So in July 2020, the Board of Health solidified our commitment to health equity by adopting the Health Equity Response Resolution. Now, in the preamble of the resolution, it discusses how historic and present-day racism results in an inequitable distribution of power and resources, causing the health inequities we see in our community today. It shares how these inequities remain increasingly more visible during the COVID-19 pandemic, and it supports the American Public Health Association's resolution declaring racism as a public health crisis. And the resolution also outlines 5 actions that SRHD will take to promote health equity within Spokane County. And that's where the Health Equity Program within SRHD, as well as the Health Equity Report, come in. So the report that you have today is aimed at informing the Board of Health and the community on how we as an organization have been progressing and implementing the actions that were outlined within this resolution. It also discusses the goals we have for 2025, and how the Health Equity Program has assisted with implementation of the resolution. And I always like to give a shout out to my team whenever I can. So this is just a nice picture of us. We started in 2022, started with just myself, the Health Equity Manager, but since we have expanded to a team of 8. So we have 1 program manager, 1 health equity specialist and civil rights coordinator, and 6 community workers who are in charge of our community engagement work. This staffing does equate to 5.5 FTE, which is reflected within our 2025 budget request. And so I recognize we are a little tight on time, so I'm not going to go through every single action here. I just am going to highlight a couple. So again, in the resolution, we have 5 different actions that say what we as an organization will do to advance health equity within the county. I am going to highlight action 2. So it discusses how we will lead, engage, call to action community partners and other LHJs, local health jurisdictions, in strategic partnerships to develop and implement policies to eliminate health inequities, as well as providing institutional means for organizations and individuals most impacted by racism to participate in decision making. And so one of the things I do want to highlight with this work is that we have, as an organization, really worked to build our community partnerships over time and engage with a variety of partners depending on the work that each program is doing and the community's needs. There's not a program you can talk to who says, you know, we don't know who we engage with. We all engage with the community in a variety of different ways. As the Health Equity Program, we recognize that these partnerships are really important, and we share through our internal SharePoint site the partnerships we have so that we can assist other programs in the health district utilizing those relationships to help move the work forward in public health. Within 2025, we hope to continue this work and improve our internal communication. We also plan to help work with SRHD leadership to identify institutional means for those most impacted by racism to participate in our work. And then the other action I'll highlight here is Action 4, which discusses supporting ongoing and all staff professional development, specifically in competencies of health equity, cultural competency, and anti-racism. This year, we were fortunate to be able to hire our health equity specialist and civil rights coordinator. They have been developing trainings to help really set a foundation across the organization on health equity work. The first training they developed is a Health Equity 101 training, which really goes over the basics of the work and establishes that foundational knowledge. It has already been integrated into new employee orientation, and SRHD's executive leadership team received the training in August of this year. For 2025, we aim to have the rest of the SRHD staff receive the training, and additional trainings will be developed based on both community and staff needs. And I will end there since we are short on time, but if anybody does have any questions, you can let me know now. I also have my contact information on the screen. Yes, Councilman Cathcart.
Yeah, how do we define fair and just?
Yeah, great question. So part of our work also within Action 1, this year we did develop a health equity definitions document, which does define fairness. I'll have to double check on justice. We created that document in collaboration with staff through our Health Equity Committee. It's an internal committee that has representatives across the organization, and they really did a great job engaging folks on that work to say, how are we defining that? How does that look in our work? And how can we make sure we know that? So I don't have those definitions off the top of my head, but I am happy to share that document.
Yeah, if you could, that would be great.
Absolutely.
Take a look. Thank you.
I'd like to know how your programming or your work here is being received within the district and even out into some of the community partners that you're reaching out to, and also how you address problems when you run into some of those issues, because there's a big learning curve with, you know, people in general, and some of the language that's related to equity is a big barrier for people to be able to come together and you know, get on the same page. So I'd like to know how that's going for you and what you're doing to solve some of those issues.
Yeah, absolutely. Speaking for myself, so far, our work has been very well received by staff of the health district, as well as community members. We've been able to create a lot of great engagement opportunities and partnerships since we started a little over 2 years ago now. When we do this work, we do make it a point to recognize, like, we don't know everything, right? We're only experts in our own lives and our own lived experience. So we always approach it from a learning point of view, really wanting to work with folks and ask, you know, where are you at? What are the issues you see with different health topics? And how can we come alongside you and help? And then when it comes to kind of the language piece of it, again, that's really where our definitions document is really handy. It was one of the first things that we as an organization really worked on to really make sure that we know how we're approaching and using this language. We recognize not everybody does that in the same way, but the more clear we are about saying, here's how we're using these words and saying this language, I think it can really just help bridge some of those gaps and barriers we come across. Because again, we can be saying the same thing, but mean very different things. So it also helps avoid a lot of miscommunication. Any other questions?
So, yeah, I jotted down a couple of words. So it sounds like you have kind of a dictionary of terms that you guys have defined?
Yes, and for the record, it is not definitions we have made up. It is definitions we have utilized from other sources that that really do this work day in, day out. We are very conscious of the fact that like we are not Webster's Dictionary. We that's not our role in this, but recognizing that even different agencies who do work in health equity use the terms differently. So which definitions best fit how we were using it internally. And then one other thing to quickly highlight, this work, the definitions document, also aligns with the public health accreditation standard. So while we aren't currently public health accreditation board certified, we are committed to maintaining accreditation readiness. So this also helps with that work.
Okay. You referenced Webster's. Would these definitions be similar to the Webster's definitions, or would they not?
It depends on the word you're looking at. Some might have similarities, some are contextual. So again, within public health, we have our 10 essential public health services with equity centered in the middle of them. Equity, just using that as a word, looks very different within the housing industry, right? Like when you're purchasing a house, equity means something very different. So really recognizing that, you know, Webster's is not necessarily going to have the context specific, so we really looked to see what health resources like CDC, WHO, others like that, how are they using these words and defining them, and how can we utilize that work instead of, you know, making something new.
Okay. And can you send all the board members the whole list of definitions?
Absolutely, yes.
Okay. I was told there was, and I didn't see it in any of the presentations, that the equity team has another graph I was hoping you could send out to everybody. It was the mechanisms of power graph that was presented to staff.
Yes.
Is that something you could send out to all of us?
Is it the health equity action spectrum?
It was a graph that I heard was out there. It was a mechanisms of power wheel that kind of touched on a bunch of different key terms.
Yes. I know the one you're speaking to. Yes, I can share that one.
Is that's something you can send out to everybody as well?
Absolutely, yes.
Okay. All right. Patricia?
I have one more thing I want to talk about a little bit. Just one of my growing concerns in looking at different DEI trainings and equity, and I have 3 social sciences degrees from USC, so I think I'm qualified to, you know, I know what I'm talking about with these things. One of my concerns is that there is such a focus on certain areas of things that, you know, are where there are equity issues, that there's a loss of kind of respect of the intersectionality for the other areas. So for example, women and children get overshadowed by some other issues, or people with disabilities, maybe, or, you know, obviously there's an intersectional issue with trans people who have disabilities, and there's, you know, so that I think the education that you're trying to work on is really challenging. But I just have a growing concern about that, because I think that intersectionality applies to so many spaces, but it gets kind of directed where we're going to just focus on this. And I'm wondering how you, as, you know, the head of what you're doing, how are you teaching or training or mentoring your staff in that area to stay kind of broad and be, you know, aware of that?
Yeah, great question. So first of all, kind of going back to Commissioner Kearns' question about the mechanisms of power, that wheel is part of our Health Equity 101 training that we do. Really, the intention of that is to examine some of that intersectionality within our own lives. So it really, that's kind of our entry point into teaching about intersectionality. The other thing I want to highlight is we really want to emphasize that we are the health equity program, but we are not alone in doing health equity work. So we really work a lot with the different programs within the health district to see how they do health equity work in their jobs. So whether it's finance or emergency preparedness. We all have equity within our roles, and how is that looking? What I find in my work is the what is sometimes easy. The how do I do this is the hard part. And so that's really what we try and explore and emphasize, is coming alongside folks saying, okay, where are the inequities you're seeing in your work? Identifying the populations that are most disproportionately impacted by certain health topics, and then working alongside our community partners to say, okay, here are some things we can do, and by we mean a health district, again, not just the health equity program. So recognizing that, those intersecting identities are very important to keep in mind. The data is also where we look a lot of times to really see. The challenge there is you can only disaggregate down to a certain level before it becomes small numbers, and you can't see past that. That again is where our connection with the community becomes so important. The example I always point to is if you just look at language access at the census level, you completely miss the Marshallese community because they get aggregated into other Pacific Islander languages. And as most of us know, that's a very prominent language in our community, and one we really need to be mindful of when we're talking about language access. So to kind of summarize the answer to your question, we start with training, identifying our own intersecting identities and seeing how that impacts our viewpoint and can have gaps in where we're looking at. And then looking at the data, but recognizing there's more to the data and connecting with community to help bridge where the data can't quite get us. Yeah, great question. So intersectionality is how the different identities you hold intersect with each other to either potentially have more power or less power within the society we live in. So I'll use myself as an example. I'm white, I'm able-bodied, I'm cisgendered. Those all, looking at our wheel and mechanisms of power, bring me closer to power as it is represented within our society. Being a woman does take me a step back, but doesn't take me as far back as being non-binary or transgendered. So it's really looking at how the different identities we hold really come up to a sum of our privilege and how that looks in society.
Any other questions?
I know we're getting short on time and I have to head out here for another appointment, but one thing I would love to learn more about when we have more time is how you see your work with disproportionate impacts based on income, zip code, some of those other factors of why some people have access to better life outcomes, health outcomes, and others don't. So I would love to know more about how you work with the different programs across the district, or how you'd like to also look at those. There's a lot about race and ethnicity, which is extremely important and often linked to zip code and income levels in our society, but just wondering how you approach some of those other health inequities.
Yeah, great question. So when we're looking at, and I'm going to kind of wrap up your question to discuss social determinants of health. So where we live can have a really big impact on our health outcomes. And we do have programs internally who do a lot of work there. We have within our Healthy Living team, there's a built environment coordinator who she really sits on a lot of those, a lot of those spaces to see how is the built environment being planned and executed in a way that positively impacts our health. And so we really focus on not duplicating that work, but instead coming alongside to say, hey, here's some things we're hearing from the community. Here's some things we learned about at a recent event when they talked about the built environment, and really trying to provide additional information so she can have a more well-rounded look into her work. The other thing I always emphasize with my team is we like to take a socio-ecological approach. So it's a public health framework. It's like bunch of circles inside each other. The smaller circle is interpersonal, and then it goes all the way up to higher levels and ultimately leading to public policy. And it's intended to show how interventions at different levels can have different impacts. So really that public policy approach has such a huge impact on our health. And so really what we're aiming to do is through our connections with the community, hearing the needs, hearing voices from our community partners, specifically those who aren't brought to the table a lot of the time, how can we funnel that up into some of those larger approaches, whether it be community, organizational, or policy work. So that's how we approach that work. It's still a work in progress, always a work in progress, but we recognize that really to have those long-lasting changes, we have to look at those higher level interventions. I hope that answered your question.
Well, thank you very much.
Thank you.
Okay, that brings us to our final agency report, the National Preparedness Month. Cindy.
Thanks, and thanks for those of you that can stick around. We will be really quick. We promise we'll give a real quick ending to your meeting. It's been a long day, so thank you. Cindy Thompson here. You heard me before. I also manage the immunization program. I have the privilege of managing the Public Health Emergency Preparedness and Response Program called FEPR. September was National Preparedness Month, and we were on the agenda last month, so that's why we carry over that theme. I want to just share a little bit about our team so that you're aware of us. Robin Albrandt, she's going to be sharing a little bit more in a few minutes, but she's our program coordinator. We also have administrative assistant, Ria Padolford, our medical reserve corps coordinator, Jennifer Wallace, and our health program specialist, Rebecca McMullen. To give you a real quick snapshot of how we work, we are totally self-sufficient in terms of our funding. We get some preparedness dollars through our State Department of Health, which comes directly from the CDC, and we've had that funding for many, many years here since 9/11. We also have some new funding within the last year and a half, and that's from our Foundational Public Health Services dollars. So that's the first time this program has had that funding, and it's been very helpful for us. Our FPHS funding has less restrictions for us, so we're able to do a few more things that we can't do with our more restrictive federal dollars. Dr. V mentioned some of the things that we worked on, always working on behind the scenes, and that is because we prepare for and respond to emergencies or incidents that happen in our community, whether you hear about them or not. We work a lot with our community partners in law enforcement, fire department, Spokane Emergency Management, Red Cross, hospitals, community organizations, and we all are doing the same work, collaborating together to keep our community safe. We work at the state level with the State Department of Health, and we also work with the Emergency Preparedness Region 9, which is all of Eastern Washington counties on this side of the state. We help support them and lead their preparedness efforts as well. A little bit more about our Medical Reserve Corps, and that is part of a national network. You might remember hearing about them during the pandemic. They were very instrumental in supporting a lot of the community vaccination clinics in this town. We had upwards of 700 volunteers at that time. Since then, we've gotten narrowed down to about 160 volunteers who are pretty active in our community, doing a lot of preparedness work and community events, etc. I am going to turn it over to Robin and let you summarize the last little bit of what we can do and such. Before I leave, though, you have this in your packet and let you take along with that to help yourself be prepared at home. And thanks, I'm going to give a shout out to Devin because one of the things that she does help us with is get things like that translated into other languages, which help support our community. All right, Robin.
Great. Thanks, Cindy. So as Cindy was saying, we actually do quite a few things. Our preparedness cycle, though, is continual, and you can see this. There's a few more things we've done since the this was put together in September, but this is basically what we've been doing for the last year and a half since May. We have updated 4 of our 5 emergency response plans. We're actually now updating that 5th one, but that includes how we would respond as a community event, but also our continuity of operations plan. In other words, how do we, make sure that our SRHD continues to function. We also provide a lot of training to our staff, our volunteers, and our Regional 9 partners. Everything from emergency preparedness, but also we do QPR, which is question, persuade, and refer, stop the bleed, and how to respond in an emergency in the incident command system structure. We've developed a strategic plan for our MRC group, and that's going to lead us forward in the next 5 years. We also are part of a pilot program with the World Institute of Disabilities. We have right now a health equity and a disasters task force. We've been working on this for the last 2 years. That task force includes members from not only that are consumers, but are providers, but people that are disabled. We have members from the index. We have members from emergency management. We have members from the Housing Authority. So we have quite a few people that have come together, and we're really looking at how we can develop some processes, recommendations of going forward to try to minimize those disparities that are caused from disasters. We have responded 3 times, once to the fire. We've done measles. We're in the process of doing a few more right now. We also have completed more than 5 exercises, and we've participated in 8 exercises. One of the things that we do, as Cindy said, is we are the lead for the Region 9 local health jurisdictions, so we do support their work and help them with their exercise and planning. And working across the divisions, we've also assisted with Mark's group on helping them with their C. aureus tabletops that they developed for the long-term care facilities. But lastly, what we really want to talk about is what this role is for the Board of Health. You're all familiar with your requirements for the RCW 7.05, but it's also important for you as our Board of Health to participate in exercises and trainings that come along. That can be emergency management for senior officials or the National Incident Management Systems overview for senior officials. We really, enforce and control and prevent the prevention measures through the local health officer, in other words, police support, Dr. V. Be involved in those major policy decisions as requested. We ask that you stay informed, support, and pass along the key messages that we have, and be an advocate for your continuity of operation planning for both the county and city agencies. That's important that we are all able to survive. And most importantly, as Cindy said, make sure that you are personally prepared, you and your family, which is one of the reasons why we wanted to share with you the handout that we have. With that, I know we went as fast as we could. We do appreciate your time, and thank you so much. Please contact us if there's any questions, or if you have any right now.
Any questions? Yeah, great. If I could just ask what, so last year, Grayson, Oregon road fire, what role did you play in that? During the disaster and after?
We'd had a lot of different things. One of the things that I think was really important is that our Medical Reserve Corps did help out in the family centers and the reunification centers, so we did do that. Another thing, talking about the partnerships that we do, there was a gap for people that were deaf and hard of hearing and trying to get information, so I actually connected emergency management, Simone, with Jim House, who's actually our state, Washington State Inclusion for Disabilities and Disasters, and connected them together. So it really did help, and we were able to identify some people that needed some resources that weren't getting them because of language. They obviously couldn't hear, and no one was helping them with making sure that they had the opportunity to get the information. So that's just a couple of the things. Cindy, you want to add to it?
Yeah, just another thing that kind of goes unnoticed is Kelly, sitting over there, the communications expert. We all are always in communication. Dr. V, Kelly, myself, usually Mark, Robin, after hours and on weekends, because we noticed a gap in communication. Our emergency management department didn't have enough staff to help get the messaging out. So Kelly was pushing out, evacuation areas, helping respond to some of the social media questions that were going on from the public. That's another role. And then Dr. V and I coordinated all weekend long with healthcare partners. Probably one of the most important things we forgot to mention is our own staff, because we had staff in those areas, and Lola was on that weekend with us, making sure that our staff were cared for. If they needed anything, we knew what those needs were. Yeah.
So that just kind of pulls into that continuity of operations plan that we implemented that piece of it internally. So that's why that's so important.
Thank you. Dr. V?
I just want to comment on that, because one of the things that we did that I thought was very unique, so although we may not have jurisdictional authority over a lot of things that happened with the fire, we utilized our resources as the source for anyone that was looking for information, whether it was what to do after a fire, how you clean your property after. So we had a lot of resources that we were directing people to that were not available in any other form. So since we cannot control the fire, we're not part, we work with our partners, but we don't have the authority. We took the role of, we're going to be the repository of useful information for the community, for everyone in the community, regardless of whether they have an impairment or not, and how to push that out to all of them. So we did that very actively for quite some time, and the feedback I got from even our own partners in the Department of Health and Fire Department is it was great, because it allowed them not to have to focus on, am I getting information to people, and actually focus on what they were there to do, control the fire, as opposed to dealing with all of the other issues that were happening. So we had all of that on our website, and was updated pretty much daily as information came through. So that's one of those things that our partners were directing everybody to our website to get the information, as opposed to having 10 different sources for the same stuff.
And then really important was our environmental health team, who fielded a lot of questions about, what happens with cleanup, et cetera. Yeah, so, yeah.
Okay, thank you.
All right, thanks. Thanks for hanging out and listening.
Oh, yeah. Okay, board member check-in. Patricia.
Well, it's been a lot going on since the last meeting that we had, and a lot of information to take in from people, and a lot of difficult things to consider. We're working on the strategic plan, so that's kind of exciting and interesting to hear everybody's feedback. There are boards with all different opinions on them, and then they put red marks or blue marks if they agree or disagree with different things. That's been really enlightening to see the things that people are lots of red marks, and other things where they're totally approving of them. So I'm excited about what will come out of that process.
Okay. All right. Go around the room. Anybody else? Feel free to. No? Okay. All right. Well, that will bring us to, it is 3:24, and we are adjourned. We'll see everybody back on December 5th.